if you want to come on and sit up here, that's fine. But otherwise, I can just sort of call you up when your time is ready. And with that, I'm going to go ahead and introduce Stephen Cohen and hand over controls to you.
Chris, thank you very much, and good morning. And with this focus in terms of the integration of administrative and survey data to inform medical expenditure analyses, actually many of you are making decisions in terms of your insurance coverage, and it's actually some of the integration of administrative and survey data that perhaps the Washington Consumer Checkbook, if I'm allowed to say that, puts out information in terms of decision making there. So that's one example of the utility of the data, but there are challenges, of course. So in my talk, I'm going to give you a flavor of the importance of medical expenditure data and the need for accuracy on that front. I'll talk about a data integration model to enhance the quality of the ultimate linked data. I'll talk about sources, core sources of data to inform medical expenditure analyses that are out in the public domain or in enclaves that could be accessible through data use agreements. Walk through many of the topics that Bob talked about in terms of some of the quality paradigm indicators when one makes a decision for the utility of the data, and actually then go into some national survey efforts that actually take that model and produce estimates based on data and turn to the opportunities and challenges that each of these endeavors create. So healthcare expenditures capture 1 out of 6 dollars going to GDP. Actually, it's about 18% of GDP right now. There was a time where there was some moderation of that rate of growth, but it continues to peak up, and it's one of the highest components of many state budgets as well as federal budgets. And the distribution is highly concentrated. It's not a uniform or a normal distribution. A very small percentage of the population consume vast quantities of healthcare services in a given year. And a focus on having accurate data for modeling to understand cost containment strategies is really pervasive. And some of the things that are going on the Hill right now in terms of the implications of tax reform or changes in the legislation for the Affordable Care Act or for CHIP or for the programs like Medicare and Medicaid have major impacts on overall expenditures. And clearly, the data is critical to identify healthcare disparities, looking at burdens individuals with chronic conditions face, and clearly informing a very important part of the economy. And so the data integration model that I'll be giving attention to is a methodology, a process in which related data, supplement data are connected in a unified structure. That unified structure is critical to the process to facilitate estimation and analysis. And here, this integrated platform has a model where the whole is greater than the sum of its parts, that by the connectivity of these data resources, each of the components that are connected actually gain in analytical capacity as well as the entire endeavor. But with more data comes more concerns in terms of each of the components have been carefully gone through a confidentiality protocol, but what's known as the mosaic effect with more combined data is something one has to have more control, more restrictions, and having work done in data enclaves. And so many survey designs are considering this feature, and what this requires is a direct linkage between a core survey and perhaps a host survey or a frame that would be administrative data from which to take the sample in a very efficient manner. And some surveys actually have link components for follow-up information to other administrative sources to help improve the quality and the capacity of underlying data. Clearly, in its own right, it serves as aggregate data for modeling purposes, use of secondary data to inform analysis on medical expenditures. And with a linkage to an administrative file, it really helps in terms of some of the survey adjustments for non-response, for post-survey adjustments, post-stratification, and to the extent there is some tension between the quality of the core survey versus the administrative data, some methodological analyses are possible for measurement error corrections. At the same time, the need for more attention to confidentiality is front and center. So talking to some of the core data that one would mine in terms of making medical expenditure analyses, clearly the Centers for Medicare and Medicaid Services have a wealth of administrative data. For Medicare, they have the enrollment files, and then they have the claims files, which incredibly deep in terms of sample size and in terms of the detail in terms of the payments that are ongoing. And in a similar venue, there's the MAX file, which is known as the Medicaid Analytical Extract file, which would have information on Medicaid eligibility and service utilization and the related medical payments. Following this protocol, in terms of having a rigorous standardization process, there is a resource known as the Healthcare Cost and Utilization Project, which the Agency for Healthcare Research and Quality actually brings together state hospital discharge data and puts it together into a unified structure to represent 98% of all hospital discharges. And so you have a wealth of data on charges and costs. It's not direct on payments, but it's the charge and cost dimension of the expenditure paradigm. And following that protocol, many state efforts have been going forward where there's a certification process and they produce an all-payer claims database, a very, very rich resource to inform medical expenditure analysis in its own right. Clearly, the medical billing systems, each of the major healthcare systems, and even the small provider offices have this wealth of data that could be tapped, but it's not in a standardized structure where it's all combined. You would have to do these one-off links to those resources to actually effectuate an enhancement to a given survey to the extent that's feasible. And in a similar venue, pharmacies have a wealth of billing data at the corporate level or even at the local retail pharmacy level. Some other major players in the field in terms of at least informing behavioral analyses in their own right in terms of being administrative data resources, big data platforms in terms of having information on payments and expenditures would be the market scan data being front and center in terms of a very large data resource of convenience sample data from large employers having proprietary claims data. So through agreements, one could get access to that data. In a comparable manner, there's the Healthcare Cost Institute coming together with another resource of over 100 million lives in one of the enclaves with claim data on payments for data from the large national insurers. There's a resource known as Optum Labs. It's a warehouse, again, administrative claims from over 100 million individuals with clinical data from EHRs. And just to segue to EHRs, with more adoption and meaningful use and the standardization of some of the information in addition to diagnoses and procedures, the payment information will really provide a rich resource in the future to really accelerate acquisition of data to perhaps supplement or even replace some survey efforts that go after that information. So then I'd like to turn to some of the issues one would consider in terms of utilizing these administrative data resources for either in their own right an analysis or for a linked methodology for a given survey component. Many of the dimensions you've seen in the CN Stat report, let me go over them briefly. Clearly, there has to be an understanding of the purpose and the content for the data resource you're tapping into, issues of the definition and standardization so that if there are different enclaves for comparable resources that one would pool, that they're following the same unified structure. And with the concept of medical expenditures, it's not just one dimension. There's the underlying charge, like the charge master in hospitals, which is the retail value. And then there's a negotiated payment, which is really what's being measured for most of the studies and when we look at components of GDP in terms of money that changes hands. And then there's what it actually costs. So understanding what is being measured in each of the administrative data resources is really critical to the process. So, and that turns to issues of compatibility and comparability, the issue of the clarity and the relevance of the analytical issue that's being addressed and the platform that's being considered to answer the analytical questions at hand. And clearly, let me just go back to issues of representativeness. That's front and center. Understanding clearly what is the overarching segment of the population that's being covered. As I said, for CMS, rich data, but it's for a segment of the population, Medicare and Medicaid, and clearly that's 100 million lives, but for a survey that's covering the entire population, that is only a component of what's needed. Issues of the quality and the accuracy of the data, the size is a major attraction for drill-down analyses, and to the extent surveys could be complemented or supplemented with data from these auxiliary sources, one can gain substantial precision. But accessibility is a concern. Certainly, sometimes there are data use agreements, there are issues in terms of cost to get the data, and one has to consider the ability to make that investment. Is the return on investment worth the commitment of the dollars? And then issues of the timeliness in terms of is the data is required, is it available to inform the issue at hand? So let me talk about administrative files that are actually serving as sampling frames for some statistical surveys in the federal sector. The Medicare enrollment files are tapped for a key survey, the Medicare Current Beneficiary Survey, that gets details in terms of the utilization, behavioral analyses, information on health status, in addition to those areas that are covered by Medicare, services that are not covered by Medicare are picked up by the survey. But the sample is drawn from the files. It permits a very efficient sampling methodology, allowing for oversampling in a very efficient manner of key survey characteristics. And as I said, you have expenditure, sources of payment, and all the services for Medicare beneficiaries. It also permits, at the micro level, given that this is an administrative data source that is on the survey, the ability, as the survey is being conducted and the data comes back from respondents, to do a reconciliation. And clearly, respondents over a given period of time might have some errors in terms of remembering all the events. So you have a reconciliation to improve the accuracy not only of the count data, but of the expenditure data that would be on the final file. Another survey that really is a quintessential model for an integrated design is the Medical Expenditure Panel Survey. It's an ongoing survey of roughly 14,000 households, 32,000 individuals, sponsored by the Agency for Healthcare Research and Quality to get details on healthcare costs, on expenditures, on sources of payment, on utilization, and information on access and quality. It gives distributional estimates, ability to do not only aggregate analysis, but all the behavioral analyses are what the drivers of expenditures are, and it has a longitudinal component as well, and allows for drill down of fairly high cost, high prevalent conditions. So in terms of details of the integrated design, the household survey, right at the start of the design, recognizes individuals in the household are good at reporting their insurance coverage, their health status, their utilization, but financial transactions are questionable in terms of knowing the final payments that have been negotiated. So right at the beginning of the design, there's a component that's known as the medical provider component, where permission is given from household respondents to go to the medical providers to actually get information on the expenditures. There's also a medical organization survey linked to it. There's an insurance component that actually builds on some administrative data and actually links in the household data with some microsimulation and modeling work. And as I said, it has a longitudinal design, but through its linkage to another survey, there was a larger host survey sponsored by NCHS CDC, the National Health Interview Survey. There are agreements to actually link HIS and MEPS to the CMS claims data. So one has this opportunity to conduct methodological analyses, to actually look past the survey window of time to future expenditures for a cohort of these beneficiaries. And it also allows, there's linkage to the death index. So one could do post-survey analyses as well. And again, of course, there's data supplementation from administrative data sources at the state and county levels. So just a little bit more in terms of the attraction of going to administrative data through the medical provider component. It primarily is serving as a mechanism to correct for household item non-response on expenditures, and it is the primary source of the expenditure estimates in the survey. It also serves as an imputation source for the missing information for all the visit counts across the different services that people incur over the course of the year. And so this just gives you a flavor of the sample going to all hospitals, a very large representation of office-based physicians, pharmacies, getting details on visits, on diagnosis and charges, and just some information on the counts. So with this protocol, you have data from both sides. And when you have it from both sides on the household and the provider, the decision has been made to take it from the provider. When there's no information from the household and you have it from the provider, clearly you take it from the provider. When you have it from the household in the absence of provider data, one could arbitrarily take that household response, but having, if you look back to the first row, the relationship information to see how aligned the two sources are, it would afford recalibration if that would be needed to make comparable estimates across the board. And then for non-response on both sides, the billing records, which are administrative in nature, are used as the imputation source. So just going a little deeper in terms of some of the overarching opportunities and challenges, as I mentioned, having a very large administrative resource allows one to look at rare populations in a very cost-efficient manner. It would be, for medical expenditure analysis, looking at individuals with specific chronic conditions, those with multiple inpatient stays in a given year, specific procedures, the high flyers, those that have 1% of the overall expenditure distribution is, if we look at the top 1% of individuals, they comprise about 20% of the expenditure distribution. So bringing them in for subsequent analysis or a longitudinal profile in the future is critical. And in their own right, they serve as a benchmark for survey estimates, looking at trends over time on growth in expenditures and changes in utilization patterns, which are a function that drives the expenditure. So you've got to get the utilization counts correct as well, and the administrative data provide that mechanism as a benchmark source. But at the same time, there's the challenge in terms of the representativeness. Is it just for a segment of the population? Do we know the actual coverage issue, as Bob alluded to in the CMSTAT report? For some of the Medicare, Medicaid populations, there is like managed care and how you quantify that. That wouldn't be readily available in a claims database. And for the uninsured population, data resources to identify them are fairly sparse. For data linkage, clearly secondary sources, aggregation of the administrative data where one can link that to the surveys for multivariate analysis would be key. And again, when it is available, as I said, informing some of the quality of the post-survey adjustments in terms of non-response, post-stratification, serving as a source for imputation, and in some cases you have a measurement error mechanism to evaluate and make recalibration adjustments. But again, there are these issues of access and ensuring confidentiality and the time to get the approval through a data use agreement and being able to get into the enclave in time to do the work you need, getting the appropriate permissions. And the other issue, I just want to go back to Bob pointed about the linkage issue. Just consider in the medical expenditure panel survey, you have the same provider. The provider was identified by the household. You go to the provider. but the links are at the event level, and the household might have, one individual would say 5 events in a given year. The provider actually has 7 in that billing record. And so sometimes even the dates aren't consistent. How do you minimize the type 1 and 2 errors and recognizing there is that source of error, even in a very clear-cut design that has a clear-cut linkage right at the get-go? Other attractions for these large data resources would be having such a wealth and drill-down capability. One gets an early signal of certain relationships, pending health problems, impending threats, hidden patterns, previously undetected relationships, and this really stimulates research and perhaps a greater focus in oversampling in some of the core data resources individuals would want and would inform health policy on expenditures. Again, more attention to looking at the impact of more linked data for perhaps some concerns on disclosure. Having really well-designed methodologies to minimize disclosure and enhancements to avoidance of disclosure to minimize the impact of the mosaic effect. And one other opportunity of these existing data resources, whether it's administrative data or even some of the less well-defined data resources that were identified in the CN STAT report, to the extent one can model and identify the subpopulation that that source is providing estimates for, there could be an opportunity. It's very much like the non-probability compositing model that's being worked on right now for these hybrid designs. To the extent one could get the signal right and build a composite estimation strategy, there are a lot of attractions to that approach. Now, clearly, there's a lot of research needed for that. That's really at its infancy, but that definitely is a challenge and an opportunity. Again, targeted applications for survey that require oversampling of these rare populations, it definitely is a value, cost-efficient strategy if one could get the access. So in closing, I've given you a flavor of integrated designs in general to support medical expenditure analyses. It is a model for enhanced analytical capacity and data quality. There are a number of challenges to make this possible, to realize all the gains, but the gains outweigh the challenges, and more work is necessary to actually improve all the gains one can actually seize from these linkages. And I really turn to all of you to pay heed to some of these opportunities for future expansions of linkage to enhance the quality of the underlying survey efforts that we do, all of us count on in the federal sector and from the research community at large. So really, thank you for your attention.